Family mode.
Hello everyone. Thank you for joining Family Caregiver Alliance for today's webinar on pain assessment in advanced dementia presented by Dr. Lise McCarthy. This webinar is open to caregivers and professionals. CEUs are available through the Board of Behavioral Sciences. In order to obtain your continuing education credit, please email adugay@caregiver.org with your name and license number or other ID number. I am AJ Dugay, the Education Coordinator for Family Caregiver Alliance. Let me give you a little background on our organization. For over 35 years, we have been working through the Bay Area and across the nation to improve the well-being of family caregivers that are providing long-term care. We offer support through educational classes, workshops, fact sheets, retreats, caregiver support services, research, caregiver advocacy, and more. For more information, please visit us at www.caregiver.org. For the duration of the presentations, your phones will be muted. If you have any questions, you may ask them throughout the presentation by going to the GoToMeeting question box on your screen. Dr. McCarthy will be able to answer these questions at the end. After the completion of this webinar, you will be sent an email with a survey. Your feedback is very important to us in shaping our future educational programs, so we would like to thank you in advance for filling those out. Today's speaker is Dr. Lise McCarthy. She is a board-certified clinical specialist in geriatric physical therapy, and she has a home health outpatient geriatric practice in San Francisco. Without further ado, I'll now turn things over to Dr. McCarthy.
Thank you, AJ. I want to say welcome to everyone. I understand that we have people all over the United States, which is pretty cool, and wanted to welcome you all. We have a few things that we need to attend to as far as the course objectives, and I wanted to review them with you now. In this 1-hour webinar, we're going to discuss current geriatric pain issues, especially for people with dementia. We're going to know how to use a tool called the PAINAD, and this PAINAD tool is used to help detect pain in people with dementia, and it's important too to understand its limitations. And we're going to identify some other pain assessment tools as well. So I want to make sure that we are all on the same page. And when I look at dementia and I look at pain, it's really, from my research, taking on a much broader look and seeing what people are doing across the world, not just in my community and in the United States. And there has been a number of studies that have been coming out since about 2005 that looks at pain and looks at dementia and looks at aging, growth expectancy factors. And so this slide is really to kind of help everyone understand what's happening now and what's projected to happen in the future. So right now, at least this was recorded a couple of years ago in 2012, there's 500 million people who are currently on the planet who are over the age of 65. And when we look at developed countries in the next few decades, what we're going to see is that those populations of people are going to grow exponentially, and they're going to generate a difference in how populations are looked at as far as services, because there's going to be a greater need. There's going to be a 35 to 44% increase in populations of people in developed countries in the next few decades. And these are people who are over 65 years. And for those of you who understand geriatrics, geriatrics is a very long span of 40 or 50 years. So that now when we look at people who are in the geriatric age group, the average life expectancy in a few decades is going to be 90 years or greater. And children born today have a 1 in 4 chance of reaching 100 years of age, and that's pretty phenomenal. When I look at the geriatric population, though, because of the work that I do, I think it's important that we pay close attention to how many of these people actually have dementia. So I have a little quiz to demonstrate and start to get you to think about the people that you know and the people that you work with when you're looking at dementia and factors that could explain some things going on in their lives. So right now, and this was taken in, this information was gathered in 2011. When we look at people who have dementia in the United States, how many of you do you think that are age 65 have dementia? Do you think it's 13% of our population, or 25 or 31% of our population? And then we look at old age, which is people who are 85. Do you think it's 40%, 50%, or 60% of the population at that age have dementia? So if you look at the young geriatric age, according to a study that was done in 2011, 13% of people who are age 65 have dementia. It might not be necessarily diagnosed, but that's the research that has been published so far. So when you think about the people that you know who are 65, if you have 100 people in a room, 13 of them have dementia is what the information is suggesting now. For people who are of old age, people who are 85 years and older, at least 50% of that group has dementia. That's a lot of people with dementia. Now, I'm a physical therapist, so when I look at people and treating them, a lot of the times I'm looking at how I can help improve their comfort and quality of life. And one of the things that I look at is pain. And this slide actually is to show you that as we age, there is, in every population, pain issues. So in early adulthood, 7 to 20% of this group experience pain, and the pain sites are generally head, abdomen, back, and chest. When you look into middle age, which is 50 to 65, you're looking at 20 to 65% of this group of people experience pain. And the pain sites are the same. But remember, people who are 65, 13% of those have dementia. When we look at the older group of folks, 85 years plus, again, 20 to 60% experience pain, and interesting enough, the pain sites are the same: the head, the abdomen, back, and chest. But remember, people who are 85, there's a 50% chance that they have dementia. So that's a lot of people with dementia in these two populations that are experiencing basic pain just because of their age. There is one pain exception, though, and it has to do with how our bodies degenerate over time as we age. And exponentially, there's an increase in pain that's associated with people who have degenerative joint disease, like arthritis. And with this slide, there are 3 points that I want to convey to you. So the first point is that when we look at people who are in nursing homes, the research right now shows that 80% of all the people who are residing in nursing homes suffer persistent pain. Now, the interesting thing about that is that 75% of all the nursing home residents have dementia. So when you look at a group of people in a nursing home, let's say there's 100 people in a nursing home, 80 of them are experiencing persistent pain. 75% of them have dementia. And if we look at that a little further, 66 residents who have dementia are also experiencing pain. That's a lot of people with dementia experiencing pain. And there's been a lot more study into why that is and how to effectively treat that, because there's a lot that goes on with pain that, when it's not treated, can lead to some difficult behaviors. Which brings me to point 2. When people have chronic pain, there's also a number of increase in the risk of falling. People get more depressed, they have more disability. Overall, they have a lower quality of life. Now, we know this information, but point 3 is sort of where we are right now, and this is from information that's been published just in the last couple of years, from 2011 and 2012. And what the research is showing is that across all settings, that means hospital settings, nursing home settings, board and care settings, etc., across all settings, chronic pain is underassessed. So if it's under-assessed, that means that it's underdiagnosed. And if it's underdiagnosed, that means it's undertreated. So how is pain then being assessed in people with dementia? That's the big question. So when we think of pain clinically, at least when I think of pain clinically, I'm looking at how the brain perceives pain. And there are two main systems in the brain that help us understand pain and to put it in proper context. We have the part that allows you to feel pain and discriminate and other types of sensation like physical touch or warmth or cold. But there's another part of the brain that allows us to put it in context so that we know what to do with that information. So when we think of people who have Alzheimer's dementia, for instance, the question then becomes, can both of those pain systems in their brain still function properly? And there was a study that was done back in 2005 that did some really in-depth research on pain, specifically in this population of folks with dementia. If you're interested, it's a really good study. It's by Eric Schroeder, and I didn't put any statistics from this article up here because what I think is so profound is a couple of statements that the authors made from this research study that they did. And what they found is that patients with Alzheimer's disease can still differentiate between tactile or touch and painful stimuli, even in advanced stages of the disease and in the presence of blunted autonomic responses. And the blunted autonomic responses basically means that if you have a cognitively intact brain, a healthy brain, your brain tells your body what to do. And so clinically, if somebody is experiencing great pain, the brain will respond in ways like increased blood pressure, increased heart rate. But when you have a diseased brain, that's not necessarily something that a clinician is going to pick up. You could have somebody with Alzheimer's disease who has significant pain and has a very normal blood pressure and a very normal heart rate response. And it might be because of the brain itself is not functioning, or it could be that they're on some medication that blunts those responses. The other thing that the authors found, and this is a quote again from their study, is that undertreatment of pain and dementia is a frequent and frightening observation. Its risks increase with the severity of dementia. And this kind of makes sense to me because when you have people who are going through the different stages of dementia, they become less aware of what's going on within themselves and less aware of what's going on around them. And they really can't advocate for themselves. So I'd encourage you to look at the study and pass it along with your colleagues if you're a healthcare professional. And if you are a family or caregiver of someone that is in your responsibility, I would suggest that you could seriously consider adding your voice and being an active participant to advocate for the person you're caring for so that people with dementia are assessed for pain on a regular basis. So how do you look for signs of pain in a person with dementia? I've been in healthcare since I was 13 years old, driver in a hospital, and I'm now in my mid-40s, and I've been around a long time, and I remember the Faceplates many years ago to help healthcare professionals understand if people were really hurting or not. And I want to suggest, and I think a lot of people now who understand dementia more and more, that these faceplates really shouldn't be used anymore when you're trying to assess pain in people with dementia. And the reason is, when people smile, they are using almost all their facial muscles, and so that emotion is very precisely conveyed. And when you use less muscles in your face to express your emotions, it's more difficult to interpret what that person is actually feeling. And I wanted to give you an example by showing you pictures of Bill Cosby. He is my favorite comedian. I've been in love with this man since I was 7, when he was the voice of Fat Albert. I don't know if any of you remember that. I'm dating myself here. But when you look at his faces, and you can see that the first 3 face plates where he has no hurt or a little hurt or a little more hurt, you can see that Bill Cosby looks fairly comfortable, happy, hopeful, not in too much distress. But if you look at the last three faceplates, faceplate 3, 4, and 5, where you have, hurts a little more, hurts a whole lot, and it's the worst hurt. I look at his face, and I look at his face under faceplate 3, for instance, and I'm not sure if he's hard of hearing, he's straining to hear, or if he's upset about something, or he's, maybe constipated. I have no idea. And when I look at faceplate 4, is he surprised? Is he fearful? I'm not sure. And then if I look at faceplate 5, is he profoundly sad, or is he actually rageful? I'm not sure. And so there's a lot of people who have come together and researched this, and they've come up with a number of pain tools, the PAINAD being one, to help us understand how to look for pain and not necessarily just look at faces. You can see these are a lot of tools that people are using right now in research and out in the community. These are state-of-the-art tools to assess for pain in people who are nonverbal. And we're going to be looking very closely at the PAINAD, which is the Pain Assessment in Advanced Dementia tool. And this is what it is. Very simple, straightforward. Pretty much anybody can use it, and that's how it's meant to be used. So let me orient you to this tool. You'll see on the left-hand column that there are 5 behaviors. And the first behavior is breathing that's independent of vocalization. And what that means is you're looking for behavior that doesn't really have a sound quality to it necessarily. In order for us to speak and make sound, there has to be air exchange, but you're really looking at how a person is breathing in between their talking. And so if you see that they're breathing from your perspective in a normal way, you would score them with a 0. If you were to go to the next column under the numeric 1, you might notice that there was some occasional labored breathing going on, maybe a short period of hyperventilation, like, or maybe there was some noisy breathing, after all, a little wheezing or gasping, or there were long periods of hyperventilation showing that there's more breathing distress. You might score 2. If you look at the next behavior, which is negative vocalization, that's pretty much what it means. If you don't hear anything that sounds negative, like moaning or groaning or negative speech that has a disapproving quality to it, like no, 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 no. If you don't hear any of those things, then you would score a 0. But if you do hear those kinds of active negative vocalizations, then you would have to decide if you're going to score a 1 or a 2. And the main difference between the two of them is the intensity of the negative vocalization behavior. You can have occasional moaning and groaning. You can have low-level speech or loud moaning. And so there's a variation there between how you would score those two types of behaviors. The third behavior is facial expression. And that's somewhat similar to the faceplates that we looked at earlier. If you see somebody who's smiling or inexpressive, they're considered normal. However, if you're looking at someone and they look sad or frightened or they're frowning, you might score them a 1. Or if you really are seeing them and they're grimacing, you might score a 2. The fourth behavior is body language. And normal would be a relaxed state. You might score a 1 if you saw that they looked somewhat stressed. If they were pacing, if they were fidgeting, they seemed tense. And then number 2 would be more of an exaggerated response where they're very tense, they're rigid, their fists are clenched. They might be pulling up their knees, pulling in their arms, getting into the fetal position. When you try and communicate with them, they might try and strike out at you or push you away. The last behavior is consolability. And that really means if you have somebody who is demonstrating any of the above behaviors, if you can distract them or reassure them by your voice or touch. And if you can, then you would score a 1. If you can't, you would score 2. So this is a very straightforward tool. I have used this in my clinical practice as a clinician to help communicate with families and caregivers, and I've taught them how to use this so that they can track if there is pain going on. For instance, when they're providing care to one of my patients, I've used this to help have an enlightened conversation with the nurse practitioner or physician who's involved in the case. And it's definitely a tool that is straightforward enough that caregivers, families, professional healthcare people can use. And it's helpful because we can all use the same language. So the rules for scoring is you really are observing 5 behaviors. You score what you see and hear. You want to observe this person that you're watching for up to 5 minutes. And you want to make sure that you're observing them during and after an active movement. And that's really important because we're really looking at if there is true pain or not. And a lot of people in the research that is about pain have found that when people are at rest and you're trying to score pain behaviors, it is not an accurate way to do that. You actually need to move them around. And it goes back to that idea that a lot of people who have dementia are older and they are dealing with degenerative joint disease in large part, and that creates a lot of their pain issues. And so you want them to be doing something. So either observing them while you're turning them in bed, or having them sit up, or having them eat or drink, having them stand up, having them walk. That's where you want to be observing them during and after they're doing something. And you want to watch them for up to 5 minutes so you get a good understanding of whether or not they have immediate pain or if there's a delayed pain effect from the activity that is going on. And how you interpret the scores is that if you score 0 after you've looked at these 5 pain behaviors, then you can be somewhat assured that there is no pain behavior presenting. It doesn't mean that all pain behaviors are not presenting. It just means the 5 that you were looking at through this tool were not apparent. But if you score a 1 to 10, then you can be assured that you actually are looking at behavior that could be considered pain behavior. And that's how we start a conversation to decide if, in fact, we need to get a diagnosis, if we need to do an assessment, if we need to get some treatment in place. So this is a slide more to the folks who are in healthcare so that you know that this is actually a standardized tool. There's been a lot of research that's come out about the PAINAD, and it was first adapted by a couple of tests. One of the tests actually was a test to look at and rate pain in infants, because infants actually can't communicate and talk, and so medical staff and clinicians needed a way to determine if in fact a baby was experiencing pain. And so that's where this PAINAD tool actually came out, is a merging of different tools and looking at pain behaviors and figuring out what is different from a small baby to a fully grown adult who is older and dealing with some pain issues but can't really verbalize what's going on like they could when their brain was cognitively intact. And what they have found is that this PAINAD tool actually differentiates pain from no pain groups. That means that if somebody is having pain and they're demonstrating pain behaviors, it's picking it up. And it also can pick up changes in pain. So if you have somebody who's demonstrating a lot of pain behaviors, you can actively give them some treatment, like maybe some pain medication, and see if you see less pain behaviors. And that's a way to track, in fact, if your treatment is effective. You might start out with Tylenol, you might then need to go up to a narcotic, and you could use this PAINAD tool to help guide you as to what is working for that person or not. This tool has become so popular, it's actually been translated into 5 different languages and is used around the world, which is important. Especially in my community in San Francisco, we have so many different cultures living here. It's also been tested on men and women in old age, and that's very important. You don't want to put a test out there that's only been tested on 25-year-old college athletes, and when you're trying to use it for people who are of older age and with dementia. This test has been actually tested on people with dementia, and it's been tested in a lot of different settings. It's been tested in hospitals, rehabilitation centers, nursing homes. It's also been tested in regular homes, board and care, assisted living facilities. And it's quite reliable, actually. What this slide means, is trying to convey at least, is that you could give this PAINAD tool to a patient. I could give the PAINAD tool to a patient. A caregiver who's taking care of that patient could use that tool. And between the three of us, we would have very good reliability that we were picking up the same information. The other thing about this test is that it has strong test-retest reliability, which means we can take it on a Monday in the morning, we can take it in the afternoon, we can take it at the end of the week, we can take it month to month or year to year, and it shows to be very reliable. It is picking up what we're looking for. It's also valid, and that's an important thing to consider too. It measures what it's supposed to measure. And so we have 5 behaviors that we're looking at, and it measures those 5 behaviors. But it does not, and this is important to know, it does not measure more subtle pain behaviors that family members or caregivers might also pick up on. And so family and caregivers are really important in the discussion about pain being present or not, because they're the folks that are going to really know this person really well. They're going to know if there's a change in this person's overall activity, if there's subtle changes in this person's mental status, and in the relationship that they are having with this person. There is also limit data on people of different races, but that's growing. There's a lot of people studying this, and there's more information coming out about different races, and so it's coming out across the board so far as being fairly valid. So I want to introduce you to an actual case study to give you an example, and we're going to then look at a video in a minute or two and have you use the PAINAD tool to gain some experience on how to rate this person's behavior, so we can get you some experience in understanding how to use this tool. So Annalise, who is was shown at the beginning of this webinar, was a patient of mine, and she had advanced dementia. I would place her at stage 6 Alzheimer's dementia. She was an alert and oriented person, but her sensory input and ability to process information was really slow. And she would sometimes talk in German and English, maybe 1 or 3 words at most, and it would often take her up to 5 minutes to engage her in something that was meaningful, getting her dressed, for instance, or getting her to eat. And she was a large woman, of good German stock, above average in height for a woman and weight, and both of her arms had active tremors. And her daughter came to me and asked for my advice, because this was a woman who's so right-handed in her previous years, and her daughter couldn't figure out why her mother was no longer using her right hand. And Annalise, when I found her, she had her right elbow tucked at her side, and she kept her right hand in a fist. And her daughter would try everything to coax her mother to use her right hand, and her mother wouldn't use that right hand. And so I was called in to figure out why. And the interesting thing is I found out she could easily open her hand, her right hand, and close it. If I put a washcloth on her lap, she could fold it. She could pull down her sweater with both hands, but she would refuse to lift her wrist above her elbow or refuse to lift her arm up. So here you can see a picture on the left where we're trying to get her to reach for a feather duster, because that's something that was familiar to her in her younger years. And you can see she's going at it with her left hand. You'll see on the table I have a 10-pound weight. We actually put a 10-pound weight on her forearm just to give her a barrier, in a sense, to prevent her from using the left hand to see if she would engage the right, and that didn't work either. So then I started to get involved and figure out what's going on with that right arm, and I'm just starting my physical therapy assessment here to see if in fact I can pick up anything that might give me a clue as to why she's suddenly not using that right arm, because I don't know if she's had a stroke or an injury or what. So So I'm on the left and she's on the right, and you can see Annalisa is smiling. So going from there, I'm going to play this video a couple times, and then we're going to review the PAINAD tool. Let's see how you would score it. I'm going to try and play it again so you can see it a second time. I'll try and get the microphone a little bit closer so you can hear what's going on. Okay, AJ's telling me you can't hear it. I'm sorry about that. I can tell you she's going, oh, oh, and she's moaning, and you can see at the end she's grimacing. I'm going to play this one more time. For those of you who are having a hard time seeing the video, I suggest you stand up and look down at your computer. There is some color differences when you change your position, and it's a short video, so we'll go over it again, and I'll tell you what she's saying. Oops. So she's saying, oh, oh. I'm asking her if it's sore, and she's saying yes. It's sore, she says, and you can see her grimace. And now she's smiling. So looking at her, you might think that everything's all right, but clearly there's something wrong. So when we look at the PAINAD tool, we can see that her breathing, from my perspective, and I know I'm sorry you couldn't hear that very well, but her breathing was normal. And then you might want to take a look at the negative vocalization and see what you might score. Her facial expression, her body language, if she was consolable or not. And that's how you would use that tool. You total up the score, see what you find. And this is how I scored her. And so I used this tool because it gave me an idea that here I was working with a woman who clearly was demonstrating pain behaviors. She wasn't taking any pain medication, and it allowed me to have an enlightened conversation with her physician and to educate her daughter on what might be going on. So we decided to put her on some pain medication, 3 times a day Tylenol, maximum dose, 3 milligrams or 3 grams of Tylenol throughout a 24-hour period. And I came back a week later and scored her again, and her pain was gone. And she had started to use her right arm again. In fact, she was in group activities where they would toss the ball or balloon, and she was starting to catch it with both hands and toss it back and forth and lifting that arm up over her head. So I wanted to say thank you for listening. I hope you will spread the word about using this tool. It's a very effective tool. If you would like some information to help you more quickly access this information, you can go to my website and look under the resources section there. I have taken 2 of my slides, basically the instructions for the PAINAD and then the PAINAD tool itself. You could download that easily and hopefully start incorporating that into your practice and to the care of the person that you love.
Thank you, Lise. That was some very helpful information, and we thank you for taking the time to share with us. So we do have a few questions, and those of you who are listening can continue to send any questions you may have about the information that was just presented on, but I'll just give you a few that I have. So the first one is, does a higher PAINAD score mean the pain is stronger?
It's a very good question, and the answer to that is initially when this PAINAD tool came out, it was the scoring actually mimicked what we're using now to describe pain. In that, you know, you have the 1 to 10 scoring, and 1 to 3 pain, 4 to was it 7 or 6 is moderate pain, and So people were using the PAINAD tool to mimic that type of pain intensity, and what they found out in the research is that you actually can't do that. It's very important that if somebody scores a 10, that you don't think they're having 10 out of 10 pain, and that it's extremely severe. What you're scoring is pain behaviors. You're trying to identify if pain behaviors are being presented. It has nothing to do with the intensity of the pain that the person with dementia is feeling. They're not really able to have the intensity of the pain. All you're doing is trying to identify if there are pain-like behaviors that are outwardly communicating, so that you can start to investigate, in fact, if pain might be really there.
Okay, thank you. And then we have a second question. Can the PAINAD tool be used on people with a diagnosis of cognitive impairment and not dementia?
Very good question. Yes, it actually can be, and more so, current research, at least in the last year and a half, that's come out is you can use the PAINAD tool on people who are cognitively intact, because these are human pain behaviors that we all have, and so it is absolutely reliable and valid to use the PAINAD tool on people who don't have dementia, who have cognitive impairment, or have cognitive impairment at all.
Okay. Okay, and then I have another question here. Where can I locate the PAINAD tool to use with my loved one or client?
So this is a tool that is becoming more familiar to a lot of folks around the world, and you can easily access it through Google. I have put it on my website, just the two slides giving you some basic instructions just for convenience. If you want to go there, you're more than welcome to download that. I put that for convenience sake, but you can easily access it through the internet just by typing in PAINAD.
Okay, that's good to know. And also, I just want to know, Annalise was a great example. Do you have any other case examples that you could share with the audience?
For video?
Or just something you could explain?
Oh, I have a lot. I use the PAINAD tool, and I've been using the PAINAD tool for a number of years, and it's helped me in a number of ways. I've had people with advanced dementia who stop walking, and I've been able to, as a physical therapist, identify where their pain source is. I think that's where physical therapy can be really helpful. For instance, a lady who actually stopped walking because she was having pain in her foot, and nobody could figure out why she was walking, but she actually had plantar fasciitis, and her physician couldn't locate it. So I went back and I just took a magic marker and marked her heel, and he was able to come back and put a shot of cortisone in her heel, and that knocked the pain out, and she was able to walk again. So again, the PAINAD is a very useful tool. It really does help to pick up pain. You might need to have somebody who is skilled, like a physical therapist, who can identify movement disorders and sort of really focus where the movement problem is coming from and where the pain source might be. But this is a tool that I use actually in my practice on everyone, whether they're cognitively intact, have a cognitive impairment, or I have dementia. And it's very helpful to track the effectiveness of my treatment. And it really does help me communicate whether or not a person needs to be on a higher dose of pain medication, or if in fact maybe some of the higher chronic pain medication needs to be reduced.
Okay. And someone just sent in, how many doctors know about PAINAD, and how likely is it that my husband's doctor will know about it?
That's a really good question, and this is one of the reasons why I'm giving this webinar. The PAINAD, at least in my area, it's in the nursing homes that I go to, and I go to almost all the nursing homes in San Francisco. My issue with the nursing homes is they're a little bit behind the times, to be honest with you, and the nurses are still scoring the PAINAD in patients when they're at rest. They're still following, old research, and they're not following the new standard research for this specific tool. So in effect, they're using it incorrectly. And because the PAINAD is used in all the nursing homes in my area, I don't know about where you are, but the physicians certainly understand the PAINAD in my area, a number of them, at least the ones that are treating patients in nursing homes.
Okay, thank you. And then another caregiver is asking, how often should caregivers use this tool to understand a loved one's pain? Once a day or twice a day?
It's a great question. So I have some people that I'm working with, for instance, I have a gentleman right now who's under my care, and he's now in stage 7. He's bed-bound, wheelchair-bound, and he recently started to call out for help. And his body was very rigid and stiff, and he was grinding his teeth. And so I was able to figure out where his pain source was. He actually had chipped a tooth, and we needed to bring a dentist in. And so the dentist was providing some numbing treatment for that. And so every time the gentleman was eating and drinking, the caregiver would just watch and see if there were any pain behaviors that were present and keep a record of that, because it would give the dentist an idea of when he needed to come back again, if in fact he did need to come back again. So it really depends on what the plan is. Remember, we're talking about pain in a population that is not really well assessed. And because it's not assessed, it's not diagnosed. And because it's not really diagnosed, it can't be treated. So if you suspect that the person that is in your care is demonstrating pain behaviors, that is the time to let the entire team of care providers and other people, the family and so forth, who are involved in helping this person, get involved and get them focused on looking at this so a plan can be made. And people can be contacted, health professionals can be brought in to determine what's going on, what the treatment should be, and then how often you would want to use this tool and why. I mean, some people, you turn them in bed, and they only have pain behaviors in the morning. And it's because they have arthritis, and they've been lying in bed all night, and so they're stiff. But maybe the treatment is that you warm them up before you turn them in bed, and then they're fine the rest of the day. So you might only want to use the PAINAD tool in the morning because that's when that person is demonstrating that they have pain behaviors.
Okay, thank you. And then another question, should caregivers possibly use the pain assessment tool to journal using this tool to share with their doctors?
Oh, I think that would be a great idea. You know, we're just right now in the nation getting caregivers to track blood pressure measures. You know, where you have the digital blood pressure machines that you get from Walgreens. This is another way to foster good communication in the home, or anywhere for that matter. So caregivers are very capable of using this tool, and the more data that is collected about this person, it can really help the medical healthcare team provide the best medicine, the best treatment possible for that particular person.
Okay. And then another caregiver just asked, my loved one has a stomach pain and the doctor said it's just a side effect of the meds, and the caregiver would hate to see their loved one in pain. What can they do?
So that tells me that there's a person that's experiencing pain, and that there needs to be a review of the treatment plan. Sometimes if people are having stomach aches because of the medication that they're taking, it's because they're taking it perhaps on an empty stomach. Antibiotics, for instance, sometimes cause the stomach to be queasy, and some types of medications that have a really strong effect, you need to take them with a little bit of food. And I have to tell you, in my practice, that is an issue that does come up. People do have stomach aches because of medication that they're taking, and that's a way to get the medical health care team attuned to what's going on, to see if in fact, you know, an idea or a plan could be changed, like make sure that the person eats a certain amount of food, maybe 20 minutes later they take their medication, and see if those pain behaviors are reduced or go away.
Okay. And I have another caregiver asking that their loved one won't let them go near his ear. How can they assess for pain with this tool?
So you probably, if you have somebody who is not going to let you touch their ear, that is a big red flag for me that there's something that needs to be investigated, and you probably need to have a healthcare professional take a look at that. There's a reason for that. People who don't have pain or are not in distress don't have issues with body parts being touched in a way that is appropriate. And if the person you're caring for is really sensitive to their ear, there might be something going on in that ear or around that ear that is causing them to defend themselves and prevent you from doing anything to that. That's the kind of thing where you would want somebody to take a look inside the ear, or maybe look at what's going on around the soft tissue of the ear to see if they can see that there might be something going on. The ear is a very sensitive place for skin damage, and a lot of older people get skin cancer, and so you definitely want to pay attention to this person's behavior and get them in to see somebody that understands how to work with the geriatric community if there's someone in your area, especially a specialist in dementia care.
Okay. And one more. So this caregiver's doctor doesn't know about this tool. How can they advocate for PAINAD?
I think just by talking about it. That's why I'm doing this webinar, is because there are a lot of, we are all people, we're all trying to do a good job. Physicians and nurse practitioners, they are people too, and they're not perfect and they don't know everything, and so they need support and help. And if you have a good doctor or a good nurse practitioner, when you have a face-to-face visit, this is someone who should be approachable, and you can share with them that you attended this webinar, or you can show them what this PAINAD tool is, and if it's a good health care professional, they're going to be curious. They're going to do that research. If it's not a good health care professional, maybe you have to look elsewhere, but hopefully you can give them a chance and talk to them and start that communication.
Okay. And have you seen any other tools that are similar to PAINAD?
I haven't seen a tool as good as this one. This one, for me, for my practice, is really, it's so simple. So many people can use this. It's so effective in helping to identify pain behaviors, most of the big pain behaviors. When I started out over 13 years ago, my practice mostly was looking at people who were 65 to maybe 80. In the last 6 years or so, my practice is now really focused on the 80 years and plus, so that right now 99% of the people I've seen for a few years are over 80. And if you have someone that you're taking care of specifically in this age range where you're dealing with old age, I really think the PAINAD is an ideal tool, because you can use it with people who are not cognitively impaired, who may have a cognitive impairment but not the diagnosis of having that, who may have dementia but not a diagnosis of dementia, and it really helps everyone's become more observant and understand what it is they are observing, so that they can really start to get that piece in place as part of the care plan, that somebody is having an issue here and that we need to get this diagnosed and do something about it.
Mm-hmm. Do you believe that pain is just part of the aging process?
Well, according to a lot of the research that I've done, degenerative joint disease increases exponentially as we age. And so most of the people that I see do have some kind of degenerative joint problem in their spine or their shoulders or their knees or their hands and feet. And it's very rare for me to come across an older person who doesn't have some kind of pain issue. It's not that everybody has one, but yes, I do think that the older you get, it's sort of like dementia. As you age, your body starts to break down and it becomes less efficient. Your brain doesn't process things as efficiently, and it can become more susceptible to different kinds of diseases. It's the same with your physical body. Your joints start to deteriorate and they start to degenerate, and osteoarthritis is something that gets worse with age, and that's very well known in research.
Mm-hmm. And I'm not sure if you mentioned this earlier, but is PAINAD available in other languages?
Yes, I think it's available in 5 other languages. Let me go back to this one slide. And I think if you look at the bottom corner here, you can see that this goes back to 2012, and you can see that it actually has been translated into different languages. The aging community globally is just working really hard, and more people are getting involved, and so it's very likely that other countries have adapted the PAINAD to their languages beyond what you see here.
That's great. And so do they use PAINAD the same way across the board, or are there any cultural barriers when they're using it in other countries?
That goes to this slide here. Let's see if I can bring you. They haven't done research on every culture, but they have done it on a number of cultures. And individual cultures, from what they have found, when you look at the reliability and validity tests that have been done, they do find that, as human beings, we generally have similar ways to express pain.
Mm-hmm.
So it can be a very good tool that way.
Okay. And can you say again what the 5 pain behaviors are that?
Yes. Let's go back there. And again, remember the PAINAD, you're not trying to identify how intense pain is a person is feeling. So some cultures may be very stoic about their pain. Some cultures may be very hysterical about their pain. What you're trying to identify is if in fact you see any pain behaviors. And so if you see no pain behaviors, and the pain behaviors are having to do with breathing changes and vocalization that has a negative quality to it, looking at sad or grimacing facial expressions, looking at the body's overall tenseness and avoidance of being touched, and then consolability. Can another person calm that person down and help those behaviors go away? You're not trying to, again, identify the intensity of the pain that the person's feeling. You're trying to identify if, in fact, you see pain behaviors. And so you may not see, in a stoic culture, you may not see some of these pain behaviors because that's a cultural phenomenon. But what you're trying to do is look at these 5 behaviors and see if you see any. Because a score of 1 means that a pain behavior is present. And if a pain behavior is present, something should be done about it.
Yeah, and you never know what else could be going on with them.
Right.
Okay, so I do want to ask the listeners, I don't have any questions right now coming in, but I'll give you guys a little bit more time if you have any questions that you want to ask. Feel free to do so. And also, Lisa, I have one more question that just came in. Are there any differences in responses to this tool based on gender?
No.
You haven't seen that?
No, and again, it goes back to this is a tool that is trying to identify if, in fact, a person is outwardly expressing pain behaviors. So it doesn't matter, if you have dementia. It doesn't matter if you're from a different culture, from a different part of the world. It doesn't matter if you're a man or a woman or bisexual or lesbian or anything like that. What it matters is the person in front of you that you are assessing, whether you know them or not. Can you identify the possibility that there might be pain behaviors present?
Okay.
That's what you're looking for.
Okay, thank you. Okay, so thank you to everyone who has participated in the Pain Assessment in Advanced Dementia webinar today. Feel free to call us if you have any questions at 800-445-8106, extension 313, and you will receive a survey in your email that we'd really appreciate if you fill out to get some feedback for future programs. Thank you to Dr. McCarthy for joining us today. This webinar is now concluded.